Alrighty, so here we are with our CET for August of navigating a successful treatment plan. So before we jump into the many clinical considerations of this topic of navigating a successful treatment plan, I really want to explore the systemic approach just to make sure everyone here has a great understanding of kind of what that means and what we're talking about when we talk about the systemic work. So a person and family-centered approach to planning and service delivery includes fostering mutual respect, expertise, shared experiences, and partnership between the service providers, the families, and the individual receiving services. This process involves listening, thinking together, coaching, sharing ideas, and empowerment for the individual and the family to take an active role in the treatment and decision makings. It's collaborative, participatory, it improves clinical decisions, promotes a greater understanding of the strengths of the individual and the family, and improves their follow through. In addition, the person and family-centered interventions promote open dialogue between providers and families and will lead to fewer misunderstandings, better outcomes, and improved satisfaction. The application of the person and family-centered practice does require a culturally competent lens as well. Collaboration is necessary in order to have a true systemic perspective. All subsystems have a voice and need to be included. This includes all paid supports, including medical providers, as well as, very importantly, the natural supports. Being goal-oriented allows a system to stay focused and working collectively. Oftentimes, system members have similar goals, but may have a different thought on how to achieve that goal. So working collaboratively in order to identify this and determining how everyone will work collectively is extremely important. The trauma-informed care approach is considered to be an essential part of behavioral health care. A trauma-informed approach is distinct from trauma-specific services or trauma systems. The trauma-informed approach is inclusive of trauma-specific interventions, whether assessments, treatment, or recovery supports, yet also incorporates key trauma principles into the organizational culture. Trauma-informed care is a strength-based framework that's responsive to the impact of trauma, emphasizing physical, psychological, and emotional safety for service users and the providers. It's an organizational structure that involves realizing the widespread impact of trauma, recognizing signs and symptoms, responding by integrating knowledge into practice, and resisting re-traumatization. There are 6 primary principles for trauma-informed care: safety, trustworthiness and transparency, peer support and mutual self-help, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues.
Alrighty, so diagnosis. Many people question the importance of making a diagnosis in medicine, especially in psychiatry. You know, it's not uncommon to hear things like, well, they're aggressive, you know, we're treating their anxiety, they seem sad, so what's the difference what we call it? You know, let's just give them something, make them feel better. And even the medications themselves span very broad categories. So sometimes in all reality, we're not exactly sure of the diagnosis we're targeting. But what I want to get across is that doesn't make finding or attempting to find the right diagnosis any less important. First of all, we want to rule out medical issues that may need to be addressed with specific treatments. If we miss those, the repercussions can be tragic. It also helps the individual to know where their symptoms are coming from, because unfortunately in the mental health field, individuals and some systems can tend to blame the person for the disorder, and we want to try to avoid that. So when do we make the diagnosis? Well, we want to start to make it immediately, but that doesn't mean we definitely keep it. It's important to have what's called a working diagnosis to get started in navigating a treatment plan. A good practitioner realizes that it's an early thought on the case and it may need to evolve and change over time. The diagnosis in my mind is also a language. I know it sounds kind of trite to say that, but it is. It's how we explain it to the person. It's how we explain it to the systems. Perfect example is I'm constantly in contact with the educational system. And I speak with teachers, school psychologists, principals, and they'll say, oh, you know, little Johnny's hitting people. Little Johnny is a pain in the you-know-what. He's a bad kid. And then I try to go back and say, well, listen, you know, he has trauma. He overreacts to sensory stimuli. This part of his brain is hyperactive. So we want to teach people to understand where the behavioral health symptoms are coming from, and diagnosis helps us with that. It also is an important tool to communicate with fellow providers. All too often, they do not speak with each other, and they're working towards different goals, and that really confuses patients and can negatively impact the treatment outcome. Lastly, and I think today's a perfect example, diagnosis is a tool to teach. When we train younger mental health professionals and systems, these are the words we use, and helps to organize our thinking in terms of doing the best we can for an individual with mental health symptoms. So in summary, diagnosis is a tool. It's not necessarily gospel at all times, but it's necessary and helpful when used correctly. And I really think as modern medicine improves and we have more genetic and biochemical information, diagnoses will be even more accurate and probably a little less open to debate. All right, now differential diagnosis, I'm sure it's a term everybody's heard. It's basically a process of determining the cause and identity of a disorder. As I said above, we want to initially document some possibilities, but it is okay to say we're not sure, and these are the options we are initially looking at. Now, some people really want to look smart and will all too quickly give a definitive statement that at a later point will be proven foolish. The problem is being proven foolish isn't the only outcome. You may also have given the individual something to worry about that they didn't need to. A friend of mine's father was diagnosed about 3 weeks ago with kidney cancer before they really assessed it, and he's 80. So they were figuring out where he's going to live. They're going to take him to Tennessee with them, all this stuff going on. And I kept trying to support them and say, listen, we don't have the pathology back. You know, it may look bad, but we don't know. I found out actually last night it was an abscess that was infected and got walled off against the edge of the kidney. Well, they probably could have saved this family and probably me a bunch of phone calls. So yeah, you want to be careful and not jump too fast to a diagnosis. Now, in our field, I can't tell you how many times I've had teenagers where I get a referral, they're psychotic, they're schizophrenic, the prognosis is terrible, you know, it's all over for them. And I'm like, say to the family, well, did we look at toxicity from drugs? Did we look at toxicity from medications from the doctor? There's so many other alternatives. And in fact, the ultimate prognosis can be a lot brighter if you take your time and look at the possibilities. So as I said before, diagnosis is fluid and it's an ever-evolving entity. And that's okay to explain that to families. Again, you often hear people saying, oh, what a great doctor, they're a great diagnostician. Well, in that doctor's head, they're not sharing it, but there's many possible things that they're ruling out and sorting out. Sure, there are some obvious ones, but that's the art of medicine, to try to figure it out. So what I'm trying to get across here at a meeting like this, I think we should probably explain it to teachers, to people who work in the group home, to families, and to the individuals at whatever level they can understand it. It helps them, but also think about it from our perspective. It helps us as providers, because if they're thinking, oh, well, my doctor thinks it could be this, this, or this, they'll start to give us the feedback that we then can incorporate into our decision-making, plug it into our calculators in our brain, and try to narrow down the correct diagnosis. One other practical point, and this has really been, you know, something I've learned from START, record keeping. You need to get rid of all the diagnoses that were there and were not accurate. At START, I was going to say we go through reams of paperwork, but it's really the coordinators and the team leaders and Elise. And then usually when they pair through all that stuff, I don't have to go through as much of it. But it's really confusing. And an individual may go from a residential to a hospital to another facility, and they're carrying all these different diagnoses that are not accurate. It's not just annoying to the coordinators, it's actually harmful, because you could get some lazy new practitioners who are treating disorders that really don't even exist. So we really want to go through these and clarify it and clear the playing field. All right, now on the last line, this last line on the slide states that because of the above, treat symptoms, not diagnosis. This is not counterintuitive to the whole discussion of why diagnoses are important. It's a practical point that in the mental health field, there is so much overlap of diagnosis we are coming up with we need to make sure we hit the proper symptoms. So when picking medication specifically, which is what I do, if it's panic, depressed mood, or mania, I want to cover that regardless of what the diagnosis is. Several different ones could all point to that direction of those symptoms. So we want to have those dual processes going on. Pick the treatment that gets those symptoms, but also at the same time, working on understanding what is the etiology, where is it coming from, and better understanding that whole process.
I want to add too that at times during treatment with a provider, they could be making medication changes, and that could cause the individual or their system of support to feel as though maybe, the medications aren't working or their diagnoses aren't correct, and make a very rash decision. A shared client of Dr. Kent and I's in our private practice is going through this right now, as she's indicating a recent medication change, and I haven't even gotten to tell Andy this, is causing her to be exhausted. So in my last session, I had her actually pull up her Fitbit records, and she's only getting 30 minutes of deep sleep. Well, to me, that's not the new medication that is causing her to be sleepy during the day. It's likely her sleep cycles. And we did go back pre-new medication, and it was the same. So, I've made that recommendation to follow up with a neurologist that has a sleep specialty and go that direction before contacting the psychiatrist, Dr. Kent, to say, this med isn't working, because it is working in a lot of ways. And we need to figure out what's happening with her sleep, if that's the culprit of her or being her exhaustion during the day rather than a med change. So again, even after maybe diagnoses are established with medication changes, things like this can come up as well. And we don't want to make rash decisions that medications aren't working. We always want to really dig deeper. And I know with this case for George, medications are a very large over focus for him, as you read. And this happens a lot. Medications will change, and he will feel different, and that will cause him panic, and will cause him to want to change medications immediately or question diagnoses, fire his psychiatrist. So as the support network, we really want to assist the individual and assist our clients in really understanding how treatment works and help them dig further, which I know is difficult for this individual, knowing him well. But again, even medication changes can cause us to kind of re-question diagnoses and impacts of those symptoms as well. So I just wanted to throw that in there as well.
I'd just like to add, when I was putting the document together and kind of looking at the medications piece, that a lot of the side effects that he experiences is a lot of the things that he does complain about. So in terms of, he is diagnosed with low glucose, but his thyroid medication could cause a change in appetite. So if he's not really eating, then it would really make sense that his sugar is low. So I think just a lot of consistent education and training with the team is something that is probably going to be ongoing for START. But that was something that really stuck out to me when I was putting this document together.
Thank you, Lisa.
How long does it take for medication that you would start to see changes in their behavior? Or, we always play the game of the Haldol going up, the Haldol going down, the Depakote. Like, how long does it take for that to take effect?
Well, I assume I'll jump in on this one. That it really varies on the particular medication, and certain medicines you will see something in 45 minutes. Certain medicines it may take 2 to 3 weeks. So that question is a phenomenal one and should be asked of the provider, so the individual, the family, the system knows what to expect. And in a later slide, I'm going to get into the fact where sometimes it's advisable to use very low doses so that we don't have side effects. We try to bypass that from happening in the first place. But that's a phenomenal question, and it depends on which particular medicine.
Okay, thanks.
All right, this is still me. So an obsession is a thought that preoccupies one's mind. It's a symptom where one cannot change their thoughts and think of something else. The thoughts are often negative and by definition intrusive. One of the best patient definitions I've gotten through the years describing obsessions was a 5th grader who was 10 years old. he came and he told me the remote control for his brain was broken. So I asked him what he meant. And he said, if you think of your brain like a TV, he said his was always locked on the worry channel. He said he would try to change to Nickelodeon or ESPN and think of something more fun, but the remote would immediately click back to the worry channel. I thought that was really fascinating and a great explanation of how we want to control our thoughts in our brain, but in this disorder, the opposite occurs, and the brain tells us what we're going to be thinking about. Now, somatic means having to do with the body, from the root word soma. So many people struggle, as does this individual in this case, with combination of somatic obsessions. Not uncommonly, I'll see fear of food poisoning, infection, which obviously since COVID has been a big one, cancer, gastrointestinal. The GI one is extremely tricky because unfortunately the anxiety worsens and creates nausea, diarrhea, or vomiting, so their worst fears then become true. In the case we're discussing today and many others, people obsess over physical side effects from the medication, like Lisa said. It's incredibly, incredibly common. The person may overthink every sensation of the day and pin it on the medicine. So the question is, what do we do about this to have a better shot? A possibility, of course, is a placebo pill with no medication in it. And one can start with that and teach the individual, aha, you see, you got side effects and you weren't even taking it. Now, in my background, I haven't done particularly well with that because people get angry and they lose their sense of trust that you've given them a placebo. And then when you tell them they've used the regular one, you're right back to where you started. So I don't tend to love it, but it is an option. My route is I tend to give a very tiny dose for a while where I sort of know it's not really doing much and they don't know it's not really doing as much. This way I can see if I have a reasonable chance or if they're really not going to tolerate me using any kind of official medication. I also will sometimes try to give a short-term anxiety medicine like a benzodiazepine while I titrate up the longer-term medication to make them more comfortable. Now, again, this is a double-edged sword because they could get a side effect to my anti-side effect medication. But in general, if I explain to them, yeah, you could be a little tired, but your body's going to be calmer and it'll counteract the effect of the other, sometimes we can get some benefit. So the question with somebody like George is, how much do you share about side effects? And that is a very tricky question because I could clearly take an entire 45-minute session discussing side effects, 99% of them, which is so rare you never see them. In general, in any patient, I try to give the main ones that are most common and in particular address the ones that are uniquely concerning to that individual. For example, if someone very worried about sexual side effects, I'll make sure I focus on that, just as I would if they're very concerned about gastrointestinal side effects. So I've been doing this so long that I could tell you I was prescribing before Google, and that made life a whole lot easier because with WebMD and internet searches, it's all the more difficult. Add social media sites where someone goes on with a ridiculous side effect concern and they look hard enough and they'll find someone to confirm it. Now, I don't want anybody to yell at me. I'm not trying to get too political, but I am going to use the vaccine as an example. I have people coming to me and saying, I'm not getting the vaccine because I'll be magnetized. And they'll show me sites where people have spoons sticking to their heads. And I'm like, it's not happening. You may have a magnetic personality, but you're not magnetic. It's not happening from the vaccine. But the point of it is that these ridiculous videos and comments exist out there. So if George looks up, hey, my legs are going to turn green from Abilify, he's probably going to find a support group on green legs from Abilify. So we have to take that into account. It really does affect what we do. Now, TV did exist in my day, so I can talk about that. And we have to address it. Because if you listen to TV commercials, if you ever listen carefully, they usually finish it off by, and in rare times it causes death. That's not a great one. So we have to kind of explain that to the person where you're not going to kill you. But yes, they did mention that and why they did mention it. Now, conversely to all the negative stuff, people will march into a doctor's office and say, hey, I watched TV and Vraylar looks really cool. That person on TV looks so happy on that I want to use that one. So bottom line is, what do? Is I have to figure out where the individual is getting their information. And that's not a silly thing. Is it from their parents? Is it from a friend? Is it from TV? Is it from social media? And then try to go over their worries, explain why those things are not something that are going to be an issue. And together we try to make a good decision. But as George points out, it is really, really difficult. But we do have to take it into account.
Okay, so definitely the title of the slide is not a start word, but we hear these words often when entering a system at start. So the individual is sabotaging, but what does this really mean? What do we really think that they want to fail? Do we really think that they want to be depressed or miserable or not meet their goals? So what it shows us is that just like every other person in the world, the individuals we support have a need for control. They want control over their lives, their choices, and their outcomes. Going back to what I discussed earlier with trauma-informed care, choice is a huge part of safety. It shows us that they want to be involved, they want to make decisions, they want to be at the table. It also tells us that there's possible anxiety, worry, fear. The individual may not be comfortable with success. They may not know what to expect. They may worry about change. If you think about transitions, so when we say the word transitions, we think about, moving from one activity to the other, but it's even a transition when they have success, when they're struggling and they have success, when the support that they're receiving is positive, and that's not what they're used to, or there's a medication change and they feel remarkably better. That's a transition. And sometimes, even though we all see it as, but you're doing better, it still can be extremely uncomfortable for individuals. All of these things may look like sabotage to some, but if we look at it from a different lens, a different perspective, we can try to see their needs. We can see where and how we can support them differently, and how to help them be comfortable with that success and that change. Providing choice, safety, explanations, support, easing anxiety can assist the individual in making different choices. But it starts with the providers and the system and seeing them from a positive, strength-based, trauma-informed viewpoint to identify where the support is needed to make change. So we all saw this earlier in Lisa's wonderful write-up. This is our eco map. So START completes these for every case, and we update them periodically. We use these to visually show the system that supports an individual and where the system work is really needed. So if we look at George's eco map, he has a lot of paid support. So he has his residential team, he has therapy, he has psychiatrists, he has his DSPs, his behavior specialists, etc. Very few natural supports, really just his parents and his sister. He does have housemates, but as you can see, it is not a positive relationship. If you look through the lines between all of the members of the system, not everyone communicates openly and supportively, as Lisa talked about earlier, and there are quite a few strained relationships. So we want to always think about, where does George lie in this system? What is his role? He's at the center, but what is his role? The previous slide, I just talked about the sabotaging client. So if George doesn't have a role in his system, it's possible that it amplifies the symptoms that we've spoken about that may look like sabotaging to some. So if he doesn't feel as though he has a voice, if he doesn't feel as though he has choice or control, we may see the exacerbation of the symptoms that we have been talking about and that were in the write-up that we've been seeing for the last several years. If people are in chaos around him, and he doesn't feel as though he has a voice or choice, his over-focus may increase and cause him to find his own methods to have a voice and choice. And we definitely see this with George in regards to his medications, in regards to him most recently firing his psychiatrist and his therapist and going back to a past psychiatrist that he had also previously fired, but we are lucky took him back. So he makes those choices and those decisions when his overfocus is increasing and he doesn't feel as though he's being listened to. Our individuals have their own values, their own goals, their own ideas. They're at the center of this eco map for a reason. We are all involved in their well-being and to support them, but ensuring that they have a role at the table, that their opinions are heard, validated, and supported is really important. Education and support should be provided to assist them in voicing their concerns and needs. something that Dr. Kent talked about earlier is about, how much should we educate on side effects and information such as that. In this case, specifically with George, we all know that he has an overfocus. He is using Google. He is looking things up. He is researching. So we have to really assess what makes things better for him, to know the reality of what to expect and why it's happening, or to let him find out on his own, because he will find out. And again, help him be a part of that decision-making process in making those choices. Education is really key for George as well. So something that we had been trying to do previously from the START perspective is really educate George specifically as to why his medical medications were so important. There was a period of time where he was choosing not to take his, I believe it was his thyroid medication, Lisa, right? His thyroid medication. And we were assessing that his mood instability had gotten worse due to that. His thyroid was no longer regulated appropriately. And now we're seeing an increase in an exacerbation in his symptoms. And of course, there's frustration that he is making that choice when we all know it's not the best thing for him. But again, George is an intelligent individual and is over-focused on his medical conditions, his psychiatric conditions, and his medications. So keeping that in mind, the focus became, well, we need to educate George directly on his thyroid condition, on the importance of the medications, how that's making him feel more depressed or more mood unstable. If we're concerned regarding those decisions that they make, providing education directly to them to support them in making the right decisions, or the decisions that we feel is best for them. And again, we want to validate and understand that they have a role in those decisions. George, as we indicated, has a borderline ID. He previously was in college. He has previously lived on his own. He has a lot of skills that we really don't see on a day-to-day basis because of the other challenges, but they're still there, and he still has the need to utilize his intelligence. So we want to always keep that in mind, and not just, again, going back to my previous slide about sabotaging, not just assume that they are sabotaging because they don't care. We want to make sure that they have the education and the support to make those choices. And that, again, looking at this EcoMap, they're at the center, and we're keeping them at the center in the conversations and in the choice.
All right, so I want to kind of follow up a little bit, at least teed me up about non-compliance, because non-compliance, not as obvious as it seems. There's many reasons why it occurs. Now, some people are very oppositional and don't want to do what they're told. They may just oppose authority. And certainly as a child psychiatrist, I see that in kids and teenagers, where they're sort of, testing out their ability to, go up against authority. Many people feel they don't need the medicine and don't have a disorder. And others may simply want to try more homeopathic natural remedies. We kind of have to figure out the reason. And in this case, I think it fits where side effects may have been a problem in the past, and that's legit. Are they having those side effects now? Particularly problematic in ASD and ID, because many of those individuals may not be quite as verbal, or they may not have the ability or the social connectedness to share. I've used this example before, but I like to throw it out. This certainly new people. I had a patient who was intermittently non-compliant because of sexual side effects he never told me about. And I've mentioned him, and what his story was, he had delayed orgasm. And I, unfortunately, because of his ID diagnosis and ASD diagnosis, was earlier on in my practice, I missed the boat, and I hadn't explained it enough to him. And he ended up in a hospital with skin damage from excessively masturbating. And it was horrible for him, and my fault, clearly my fault. And I realized, you know what, I'm not going to make that mistake again. But what it showed me was non-compliance for him. He wasn't oppositional. He just had a dumb doctor that didn't tell him about that side effect. So we have to be careful and try to figure out what is causing the non-compliance, because there's a million different things that could do it. Now, intermittent non-compliance is uniquely important to discuss. Can't tell you how many of the consults I get at START are not pure non-compliance, which is actually easier. It's intermittent non-compliance. Because not only does the person not get better from the medicine, that could make them worse. And it goes back to the question that other person asked me, how long does it take for medicine to work? And how long does it take for medicine to screw you up when you miss a dose? Certain of them are very short acting, and the individual may go through withdrawal frequently. Again, I always throw out stories, and just this week, that's the life of a psychiatrist. People are always calling you and telling you their stuff. It is what it is. And I have a good friend whose daughter, she just moved to New York. She was on Effexor and she wanted to come off it. So she called her doctor in California and he said, oh, go to every other day. You can't go to every other day on certain antidepressants. Why? It's too short acting. So every other day she was having withdrawal, feeling panicky, feeling what she wanted to vomit. And that's when they called me. So I basically explained to her, you take a little bit off every few days, but you take every day. But intermittent noncompliance is something we need to keep in mind. So what do we do about intermittent noncompliance? Well, again, we try to explain to the person and give them the correct advice. That's great. Someone like George may not take the correct advice. So how about blood levels? That can be somewhat helpful, but again, it's not the perfect solution because I may get a blood level during a week where they were very compliant and not happen to get the blood level when they were not compliant. So again, it's not going to hurt, but it's not the perfect answer. I think we have to really get the support system on board because sometimes there's a split that we're not sure that's going on. Out of the goodness of their heart, there may be a family member or a staff member saying, that medicine's not great for you, George. It really never works so well. I think you're better off without it. And that really throws a wrench into it. So we want to get everyone on board. And that means if there is someone who cares about George, who doesn't like that medicine, speak up. I want to know as a doctor if someone doesn't like what I'm doing, and I can explain to them why I'm doing it, that I'm open to change, but we got to get everybody on that eco map as much as possible to be on the same page and communicate it. But when noncompliance remains problematic, we want to look at intramuscular versions of medication. That's really something to consider because you don't have that daily problem. If the person can agree, it's in there for 4 weeks, or if we get a medication like Invega Trinza, it's into 3 months. So that can be very, very helpful. But one quickie thing I want to point out is you can't jump to that because you have to test out the medication orally first to make sure they tolerate it. Because you imagine if somebody has a really bad reaction and you've given them a monthly injection, you've just sentenced them to 4 weeks of really feeling badly, or God forbid, allergies. So you have to test it out orally and then convert it into a muscular form. But for a lot of people, it really takes a lot of the non-compliance headache out of it.
One medication that I just want to mention that has come up quite a bit is Topamax. So it has the nickname Dopamax for anyone that doesn't know, because it has a really significant cognitive blunting at times. And I want to say it was another case with Lisa actually, but the individual did not want to take the medication, had some intermittent noncompliance. And in a consultation, I had spoken to her about that. Like, I wonder if it's making her feel less intelligent, less able to communicate. And that really was the situation. And instead of having her just choose not to take it, we were able to provide education to her and then communicate with the doctor. But because for that individual, she wasn't able to realize that that was what was going on for her until we provided that education, that support, and assisted in that communication. So again, trying to understand the why behind their choices, and not just assuming that it's sabotage or that they don't care. We do see intermittent noncompliance on medications from George. And again, anytime that we've talked about the case, we've kind of always brainstormed and talked to the house manager and talked to the BIS and the system of, do we think this is happening? Do we think that is happening? Talking to George himself to try to understand that choice so that we can then speak to the providers with George and have a more productive conversation rather than it potentially even harm him further because he's having the intermittent dosages like Dr. Kent just said.
What is I have a situation where an individual, the mom doesn't want her son to be on certain medications. So every time he stabilizes and he's good, the mom's like, oh, well, he's doing well. We can decrease, this and this and this. And the mom's one who is the primary care, he lives in an IRA, but they have to listen to the mom. And what are the ramifications of somebody's medication? I mean, the minute they lower it even a tiny bit, we see the difference in behavior. But what is that doing to his body of going up and down? Like today we're going to higher it, tomorrow we're going to lower it. And it's very, very quickly that they do it. You know, within a month or 2 months, that it's constantly going up and down.
Well, I think you're right on that the person will feel poorly. Again, depending on the medication, the ramifications are different, the time frame is different. I think it's incumbent on the provider to do the best they can to engage the parent and try to explain to them, give me this amount of time on. I'm a big chart person, so I'll have families say to me, you know, this is going on. I'll say, all right, give me 3 weeks and give me every day perfect. Then what do you want to do? Okay, give me 3 weeks. We're going to do what you want to do, but no changes in between. And then we'll try to compare the behaviors on the two. In theory, that sounds wonderful, but there's a lot of parents who don't follow it, and then they still make the changes even when they're not supposed to. And bottom line is you're up against it. You can only do what you can do, but it makes it so much harder.
Especially that he is in his behaviors with his parents are going to be much different than living in an IRA. You know, when he's in an IRA, there's a lot of other factors. When he's with his parents dote on him. And, you know, so of course he's going to be more relaxed. He's going to be, you know, nobody's there egging him on to have a behavior, or there's no mixtures of different personalities. It's him and his parents.
Yeah, you know, it's multivariable, and that's what we have to try to explain. Medicine is one thing, but so is, how's your roommates? Do you get along with your staff member? Did your day program get closed down? So there's so many variables. And it's funny because I use a lot of PRN adjustments depending on environment. And I got to be careful because some people get insulted. I'm like, well, when you're visiting your parents, you're taking a little more Xanax. Or if you go back to the group home, you're taking this dosage. And they're like, oh, you saying we're causing it? No, I'm not saying that. I'm saying environments are different and we want to try to adjust. That's where, you know, the START model of good communication is essential, but, you know, you can only do what you can do. Some people are just going to not get it, but we just try to keep working at them, you know, to understand, like you're saying, different places is that they're experiencing a different world.
Yeah.
I also wonder,
go ahead, Lisa.
Oh, sorry. I also wonder, you know, much like in neurotypical people, sometimes if the medication's working, and we're seeing an improvement, and maybe we need to just continue the regimen instead of kind of changing it. So I mean, I wonder about that too, where sometimes people think like, well, I feel better, I don't need it anymore, but maybe that's why you are feeling a little better and they're noticing that positive.
Absolutely, Lisa. And I think too, in regards to Kathleen's question and commentary, I think the system really trusting each other is really important, and communication. So again, the symptoms are going to look different for the client you're discussing at home, because I do know who you're speaking of, at home versus at the group home, because like you're saying, there's a lot of other factors at the group home. And the education that has been attempted to provide to the parents to help them understand the triggers are different, the vulnerabilities look different, and really helping them communicate better to say like, okay, well, that client's doing really well at home, but this is what we're seeing at the group home, and having the provider really help to differentiate that. And again, like Dr. Kent is saying, with certain meds, maybe there is a difference if it's a long visit at home versus, you know, and things can look a little bit different. I know that case, the parents are very, especially the mother is very focused on him being on less medications. And when I had that case, because I did have it for a period of time, I spent a lot of time trying to talk to her about, you know, it's not, you know, quantity versus quality. Like we need to make sure that he's supported. And just because it's 5 pills doesn't mean that he's in a dangerous situation if it was only 3. We've had situations where parents, not this case, but parents where they coming into START, they only wanted their individual on white colored pills because they're worried about dyes. And I actually think that might have been one of Caitlin's initial START cases when she first joined our team, actually. But yes. It was, right? a lot of education occurred. And eventually, Caitlin will be happy to know that that client is on different color medications and it's the right regime finally. So again, I think a lot of it is education and support, communication. And I think that trust within the system from the family to the paid supports is a large factor in the case that you're talking about, Kathleen. So really having that open dialogue and making sure that the provider is aware and educating, as well as not just making very quick changes based on one report that doesn't encompass where he really does spend the majority of his time.
Yeah, I think it's important for the provider to be the quarterback here. Yeah. And what I try to do is take the pressure off the system, off the group home. I'll take in all the information and then I'm going to say, listen, this is not a democracy. This is what the individual needs. This is this environment. They may need more. This is less. So you want the communication to be good, but ultimately somebody has to autocratically say, this is what we need to do, what's best interest in George, so George does not suffer. Again, it all sounds good to say, it's not always followed, but I think it's important to let the provider know where we're running into the problems and see if they can take on that role. Now, some don't want to do that, but I think it's our job as the doctor to really say, this is what we got to do. You know, it's not working the way you're doing it. This is how it should be done.
Unfortunately, when you deal, I love a lot of the doctors at Lish, but I do think a lot of them are ruled by what the parents want. So they do change the medication at the parents' request. And that's
right. You're right. And when I sit up here on my academic horse saying how easy it is, I've been fired multiple times for trying to stick to that. So it's not always easy.
Yeah, and I think when that happens, having that education from START's perspective, the care manager, the house, to the parents directly about the impact, because again, like Dr. Ken said, it's easy for us to say this is ideal, right? But it's not always the ideal situation. So the education outside of those 20-minute psych visits is super important for them to, before going into that meeting and understanding, you know, why do they need to be on the Haldol, how the Haldol made such a difference when that individual went on to that medication, although it's maybe not a medication that they really like, understandably so, but the quality of life piece as well. And I remember that was one of the meds that system was focused on for a long time, probably still are. So again, I think having the system support those conversations prior to the appointments, making sure that education is provided and that they understand you know, why it's important. And again, bringing it back to the goals. Our goal is to have the individuals have the best quality of life and you know, ultimately the best well-being and happiness. And if the medications are providing that, we're managing maybe other symptoms or side effects, weight gain in other ways, you know, increasing exercise, things like that, them understanding what could occur to their happiness and well-being and success should the medications change. And like Lisa said, that it happens in the neurotypical population all the time is they feel better. And now they think, oh, well, I guess I don't need the medications anymore, but the medications are why they're doing better. And I think that that's a very similar kind of phenomenon when it comes to parents caring for an individual with ID, of they see it as, well, they're doing so much better, so we don't need this anymore. When in actuality, that's supporting that process.
Can I just quickly add something?
Oh, sure, Bob.
It wouldn't be a CET without me doing it, right?
Right.
Right. So, you know, Kathleen, I think your point about like different environments, like you might see different things across those environments, and I think that's valid. But there are also some core things that we always look at that would probably there would be very little variability across environments. So things like people's sleep, their appetite, their energy level, their level of attentiveness. Those are things like those sort of vegetative signs and symptoms that we wouldn't necessarily expect to see a great variability just because of an environmental change. Yeah.
Definitely.
And just one quick practical point. If the doctor is willing to do it, if the doctor is willing to share email, what you could do is have the parent say, listen, before you make any changes, just promise you shoot me an email. and then the doctor, because the appointments could be every 1 month, every 3 months, and so much could happen by then. So if they're willing to have that communication on both ends, there could be maybe a little, let's catch it before it happens. So I don't know about George's provider, but that's a possibility.
Mm-hmm. Well, George's provider just changed to your good friend. So and it is definitely a possibility.
Yeah.
my former good friend, when I give out his email.
Yes.
Yeah, happens to be very receptive to email relation or communication.
All right.
All righty. So the biopsychosocial approach considers the biological, the psychological, and the social strengths and vulnerabilities related to mental wellness and how these different factors might contribute and influence one another. It's an important way of thinking and operating within the START program and model. It promotes the value of interdisciplinary perspectives. The biopsychosocial approach is based on the idea that each of these factors exists across a continuum and are the key to comprehensive, holistic assessment, evaluation, and service delivery. So on our screen is George's biopsychosocial vulnerabilities within this visual. So all of these things were within the document that we reviewed. Some of it's been within our training thus far. If we look at the biological circle on the top, as we talked about, he has hypothyroidism, low glucose, overactive bladder, constipation, poor diet. We move to psychological, major depressive, OCD, autism, borderline ID, symptoms of anxiety, and executive functioning deficits. And socially, strained relationship with family, feelings of abandonment, no natural supports in regards to friendships, struggling in making connections, and no meaningful activities. So when we look at this, it has a visual of this overlap. Obviously, there is a lot of overlap. Not having any meaningful activities and no friendships could lead to our major depressive disorder and our depressive symptoms, our anxiety symptoms. The strained relationships with his family could be the same. With his medications, some of those could be leading to constipation and other aspects in his biological bubble. Again, like we talked about with his inconsistent medications at time for his hypothyroidism was specifically one of George's concerns in recent months that can also impact his psychological bubble. So it's important to always kind of really step back and think about what is going on for these individuals. How are they overlapping? What is the impact of all of these areas? Again, for George, he's not diagnosed with an anxiety disorder, but anxiety is very prominent for him. His OCD is focused on his medical conditions and his medications. So that overlap is very strong for him. His executive functioning deficits in regards to cognitive flexibility and impulsivity and planning and organization all impact his other psychological factors, but also can impact his social. It can impact how people interact with him, what they perceive as his abilities, and that will impact that struggle in making connections, which again is not just to natural supports, but also to his paid supports. He really struggles in making connections to the staff in the house, in being able to feel supported when he is struggling, which exacerbates his crisis. So again, thinking about the biopsychosocial conceptualization and what I mentioned briefly about this allows us to really think about things globally. Dr. Kent mentioned a lot of medical factors already today and how that needs to be kind of presented and discussed globally, but it's a part of this larger figure. It's a part of this larger discussion. I want to stop here with this biopsychosocial conceptualization and kind of those vulnerabilities that I have on the screen and kind of ask anybody if something specific stands out to them, if you notice any specific overlaps that are really important to point out, and how this may assist you in thinking about ways to support George.
Hi, it's Alex. A lot of what resonated with me as I was listening through the uncomfortable feeling that he has with success for me was kind of stirring the idea of self-esteem and self-confidence. So I don't know if
Yes.
some area that therapy can kind of focus on and help him with, because I thought if we can use past success situations to redirect him in, behavioral health symptoms situations to kind of validate him that he has control, that he can be in charge, and that he has past references
Mm-hmm.
to help him. And then I also definitely saw the social component being big
Yeah.
in that whole thing, because I was kind of drawing ideas for areas to explore, which was like personal fitness and exercise. Now that you mentioned the poor diet, I was
Mm-hmm.
like, yeah, that will definitely also compromise everything. And then I was trying to think about with his strengths cognitively with regards to spirituality and philosophy and religion, whether there were classes at NASA that he really enjoyed. And if we take away the performance component, if we could explore like online classes that are just for him to engage in, like book club discussion, if he likes to read on those topics and discuss with others. Um, and of course, at the, at the end of that timeline, maybe like definitely relationship building. And I don't know what his struggles are there, but that's definitely something that would help him in terms of well-being.
Absolutely. Those were fantastic observations and recommendations. And I see Lisa writing, so I'm glad I'm glad we're getting those down. Thank you so much, Alex.
Yeah, Alex, I really appreciate all that feedback. That's really, really helpful. Thank you. And I sure am writing those down.
My pleasure. Thank you guys for all you do. This is really complex.
Any other thoughts or impressions?
I just wanted to, hi, it's Mona. I had to jump in. Sorry, everyone. I agree with everything that Alex said. And as far as the social and psychological on this biopsychosocial, it is so reminiscent of a client that I had. I'm sure most of you know who it is, where once she was, actually going to the resource center, and she got so regimented with taking the meds on a continuous basis and getting the social aspect had just blossomed. So I wonder if that could be a component for George. And it had gotten so well there. And that's the difference between environments, like you were discussing. It had gotten so well there that she would check herself in, basically herself, to the resource center, and now she'll be moving into an IRA. So yeah, the different environmental factors can be a real boost and can be a real stabilization for a lot of people.
Thank you, Mona. Okay.
I do feel like with the environmental, like we have, we take away a lot from individuals when they do go into IRAs and things that they don't really have choices as much as we want to present them with choices. They only really have a small amount of choices that they can make them themselves. I mean, we choose where they live because it's not, especially if they don't really have a lot of family involvement, it's where there's an opening, where, they don't get that control, like where, we talk about control and things like that. They don't have that. So I do think that they do fight to have it. So it may come out in, choosing the food or being obsessive over food, because that is their only choice. That is their only, that they can actually have that control.
Absolutely. Yeah. Go ahead, Lisa.
I think that's a really good point, Kathleen. And in George's particular case, he does happen to live very close to his family, but I could see that he did grow up in a very strict and rigid household. So I could see how a lot of that kind of would be grasping at just like a little bit of control, where to say like, no, I'm not hungry when he kind of is hungry, or being very picky with the foods that he's eating, where that could be attributed to the autism and his sensory sensitivities, but it could also be attributed to a sense of a lack of control. So I really appreciate that perspective. Thank you.
I was just going to add to what Lisa said, is that it's, when we hear the words control, it's usually said in a negative way. And you did not, Kathleen, but oftentimes it's like, well, they're just trying to control the environment. Well, don't we all try to have control over our life? So we want to help them, help systems see as control as not being a bad thing, but with providing them choice and a role, like I was talking about earlier, maybe that control, so to speak, is no longer a negative thing, and they can truly just have some control of their life, which is what all of us seek. And again, maybe with education, the things that they choose and the things that they are desiring may not be negative to them. Like, again, what we talked about earlier, when individuals may have intermittent non-compliance with their medication, that intermittent choice, whether to take it or not, is something that they really do have choice over. We can't force it. But it could be harmful to them. And that's where the frustration can be found. But again, if we help to understand that control is not negative and give them the opportunity for control and choice in their life, it may not be with some of these things that we have more concern over as paid supports. Absolutely. And Dr. Ken is going to dive way deeper into the biological bubble. So I'm going to turn the slides over to him. There we go.
All right, well, not too deep, but that'd be a whole nother lecture, but I'll do a little, and then people could ask questions. So the most classic behavioral health symptoms associated with hypothyroidism: low energy, depressed mood, poor concentration. Now, these may occur in someone who's never had mental health issues, or more commonly in our population, they may have had that, and the hypothyroidism exacerbates it. Physically, you tend to see dry, itchy skin. The hair can be a little more brittle and dry as well. You may see some weight gain. The classic goiter, which is the growth around the, of the thyroid in the neck. And that's usually with some nodule formation. It's not always present, but that's a sign to look for. One thing to point out, it's very important, hypothyroidism may cycle. For example, one of the more common presentations of hypothyroidism is in Hashimoto's thyroiditis. What this means is that it could be low, it could be normal, and there are actually times in that cycle where it could be too high. This autoimmune disease attacks the thyroid, and it's not unusual for it to speed up and then burn out. So it's like sputters and starts, sputters and starts. This is why it is so important to comply not only with medicine, but also with the testing, because it's a moving target. You can't diagnose someone with this and say, all right, this is what they need, and then do ongoing care. Be it 6 months later, a year later, you got to stay on top of it. Another thing I just wanted to point out in this slide is that lithium, which many of our people are on, has a potential to profoundly impact on thyroid function. And it's not unusual for it to result in hypothyroidism. But I want to note that if you have a client, you have a person who has lithium in their medication regimen and a thyroid problem, that doesn't mean the doctor screwed up. That doesn't mean that they can't take it. They may need the lithium. Nothing else may work because it's so unique. What it means is the thyroid has to be monitored regularly, and they're going to need supplemental thyroid hormone on top of it, which you can definitely have that occur. So before going to the next thing, anybody have any hypothyroid questions? Nope. All righty. Need the next slide, Elise. Thank you. All right, hypoglycemia, which I think Lisa brought up earlier with this dude, and it's a very important issue. When the glucose level drops, it could definitely negatively impact how you're feeling, but it's real important to know there's not a set number for every individual. Some people may feel very poorly when it drops a little, and some people may need a very huge drop to feel something. It also matters where you're starting from. If someone normally runs a high sugar and we test them and the number seems low normal, well, that may be a big drop for them and it wasn't for somebody else. So how far it's dropped, that also is a significant issue. This is why testing is key. Now, we've had several cases in the last 6 months that I've consulted on at Free where low sugar needed to be looked at. So what we do is we log the person's food intake, looking at how much they eat, when they eat it. We want to make sure the food's spread out, and we want to match that up with behavioral health symptoms. Are they stirring up at a certain time of the day? During these consultations, I realized people were kind of confusing the numbers being tested. So I just want to quickly say something on that. Hemoglobin A1C is a marker that you're prone to diabetes. Roughly above 5.8 or 5.9 shows increase in risk. It is not a good indicator for what's going on at that acute situation. So if someone hasn't eaten and they're hypoglycemic and you get an A1C, it's not valuable at that moment. That's going to be something you're looking at for pattern over time. The glucose at the time of the testing is what we want to see because that's what the body is immediately dealing with. Now, when we do regular testing, we like to get a fasting glucose in the morning because that shows us how low it naturally drops in that individual. Urine testing can have some value because if somebody is spilling sugar into it, they're probably hyperglycemic and the body is not processing it properly. So that's important too. So as I said before, there's major variation how an individual responds to a change in glucose. And in the ASD-ID population, it's more problematic because again, their skills probably not going to be communicating to you how they're feeling about the low glucose. So what do you see when someone starts to get hypoglycemic? Sweats, anxiety, irritability, a little lethargy, and thirsty. So what does that sound like? It sounds to me like a panic attack. So it's not unusual for someone to describe anxiousness and panic. And again, a personal story, in my first New York marathon, I had food poisoning, but I was too stubborn to drop out because I had trained for so damn long and I had paid to get into the damn race and I couldn't keep anything in. And by the end of the race, I had all this going on and I had a glucose that was so low, I probably needed to be hospitalized, but I did not. But I first thought I was having a panic attack. I was sweating, I was anxious, I had chills, I couldn't get myself together until I put my head on straight and realized I'm hypoglycemic because I wasn't eating anything and I was expending so much energy. So it's real important to know anxiety and hypoglycemia are so similar. And we want to think about that if somebody is presenting with those type of a symptom.
Okay. We are nearing the end. So PERMA. So positive psychology is the scientific study of strengths that enables individuals and communities to thrive. A core concept of positive psychology is PERMA, which is a theory of well-being that attempts to answer what enables human flourishing and puts a person in flow. PERMA was developed by Martin Seligman, who is considered the father of positive psychology. It's based on the idea that wellness is not a one-dimensional idea, but a multifaceted construct composed of several different elements. As you see on the visual on the screen, those elements include positive emotion, engagement, relationships, meaning, achievement, and plus, which is vitality, which includes physical activity, nutrition, sleep, and optimism. So thinking about positive emotions. So this is more than just happiness. Oftentimes when working with this population, we just think about, are they stable? No, but are they happy? Are they having positive emotions? Do they feel good about their life? Do they have a pleasant life? So it can include a range of positive emotions: amusement, hope, interest, joy, love, compassion, gratitude, pride, optimism. Again, it's more than, we want to look at more than just stability. We want to look at that they have a pleasant life, that they feel good. Engagement. So when we're engaged in things that we love doing, we lose track of time. We are living in the present moment and entirely focused on the task at hand. This is called flow. We're so intensely focused that time stops. We experience flow when our greatest strengths correspond to the challenges that we face. So this engaged life is incredibly important. We don't want to see engagement as, oh, well, they have a day program to go to. That's not what we mean when we talk about engagement. We want to talk about things that provide them the opportunity to be in flow, that utilize their strengths, that they're happy, that they're excited, that they have those positive emotions I just mentioned while doing something they truly enjoy. Relationships refer to the many different interactions that we all have with others. Authentic, meaningful, life-enhancing connections, feeling loved, supported, and valued. So this is what we mean by relationships as well. It's not just that we have people in that eco map, that they're positive relationships, that they're supportive, that they're connecting. We want them not just to have paid supports, but to have natural supports as well. Meaning is to have a sense of meaning, we need to feel that what we do is valuable and worthwhile, having a meaningful life. This looks different to everyone. It can be purpose, passion, fulfillment, belonging, contributing, being motivated. For a lot of people, that could be their career. Being in the helping profession can provide people meaning. It can be something that they truly feel is their meaning in life to provide. It can be something that they volunteer doing. It could have nothing to do with things like that. So with this population, we want to find that meaning. What brings them purpose? What do they feel passionate about? What do they feel as though they do that they belong? So that is a really important part of this PERMA theory. Achievement is also really important. Having an accomplished life. Having a sense of accomplishment means that we've worked towards something and we've reached our goals, or at least a goal. It contributes to our well-being when we're able to look back on our lives with a sense of achievement and say, I did it and I did it well. People who exhibit grit don't just finish what they started, they persevere at their goals over time. So having success, having goals, achieving those goals, even if it's just one step at a time, provides us with achievement. As we've all gotten older, none of us really ever look at this as closely as we should. When we're younger and we get awards for showing up, when we get awards for winning the soccer games, right? Those are all things that we have achievement with. When we finished our degrees, when we graduated something, when we got START certified, those were all amazing achievements that we hold very dear to our heart. But we want to think about the individuals that we support and what achievement do they feel? We might set goals for them, but what are their goals? What do they want to work on? At the Resource Center, this is a huge part of it. Anyone that's interacted with the Resource Center, of not just setting life goals and future goals, but setting goals of the day, feeling as though they're achieving something step by step, breaking down their goals and having that achievement, having that moment of success. The plus section, which is labeled as vitality, like I said, includes many different things. So physical activity, we can't achieve an overall well-being without physical health. So this is really important. People who suffer from mental health issues or intellectual disabilities may also, and are more likely to be less physically active. So ensuring they have movement and support in that area is very important. With nutrition, you are what you eat. This is a very difficult area for a lot of our individuals. We talked about before about maybe sensory sensitivities related to food choice, or potentially just wanting that choice over what they eat. Oftentimes it's not the healthiest option. So really providing that support in improving their nutrition. Sleep is a huge factor. And often when we're digging into our cases at START, we learn that sleep is disrupted. And disrupted sleep can be associated with difficulties in mood, disruptions in thinking, concentration, memory, learning, reaction time, vigilance. So it really does impact a lot of what we're talking about. So again, the goal is to increase flourishing. When we look at PERMA, we're not just saying, oh, they're stable. We want them to flourish. We want them to have a positive life, and we want them to feel good about the life that they live. Before we move into the last slide of kind of pulling everything together, does anyone have any questions about the last few slides or PERMA in general? Okay. Kathleen, did you have something? So how do we put those all together? Dr. Kent and I really presented a lot of information that, should be thought about and included in a successful treatment plan. So we want things to be strength-based. We want to look at the individual's strengths and work from there. Systemic and strategic work is incorporated. So we started this presentation focused on systems work and what does that look like? We want to ensure that those systems are working collaboratively and working from a place of that strength-based perspective. PERMA Plus, which is what I just presented in the last slide, is a core element. So again, we don't want to just focus on stability. We want them to flourish. We want their wellness to be there. How do we implement that? How do we start small? What goals can we set? What goals do they have? If we look at each facet of PERMA, there's a lot that we can do to build upon that. It's not easy, but it goes step by step in helping them to increase their positive emotions. Again, like I said, engagement doesn't just mean they have somewhere to go. Is it appropriate? Is it accessible? Do they want to be there? Is it helping them to meet their goals or providing them with meaning and relationships? Is it helping those other facets of PERMA as well? Trauma informed is something that we spoke about as well in the beginning. So that is a very important aspect for every individual. Sometimes we don't see that they have experienced trauma if it's not a major, abuse and neglect situation. But as we've talked about in a lot of our CETs, trauma is pretty much incorporated for every individual that we serve. It's hospitalizations, moves, moving into group living, away from their parents. There are so many different trauma. It's a whole training out of itself, like Dr. Kent said before about medical conditions, right? So everything we do, we want to be trauma informed and including that in the work that we do to build that successful treatment plan. Like I said earlier, and we've talked about throughout, safety, choice, trustworthiness are all a major component of trauma informed care. So pulling that together and incorporating that into that successful treatment plan is incredibly important. The biopsychosocial aspects are incorporated. So again, another very important part, if we only look at medical or only look at psychological or only look at social and we look at them in silos, we're missing a very important piece. There's a lot of overlap. There's a lot of things that if a medical condition is not treated, it's very difficult to treat the psychiatric condition because then we don't know what's causing what. Like we talked about with hypothyroidism, there could be a huge mood component if it's not properly treated. So are we treating a psychiatric condition or are we treating a side effect of a medical condition not being properly medicated and properly supported? So as with START, we always say biological first. We always want to look at the medical. We always want to make sure that that's clear because there is so much overlap. There even is overlap between the biological and the social because there could be embarrassment. There could be fear related to medical conditions. The biological can also include family history. In this case, it didn't because the family history has been unremarkable. But if there's family history of mental health, that could socially impact the environment that they were raised in. And there's many examples of that as well. And then again, this is something that we've talked about quite a bit, but the individual having a role, having a voice, having choice is incredibly important. And again, we validate that it can be frustrating at times when they change their mind or they're inconsistent. But again, we need to kind of step back and understand why are they making those choices and how can we help them make ones that are going to be more beneficial to them. We also want to include the cultural and linguistic approach. So being competent in cultural factors is incredibly important. With any of our cases at START, we always kind of start off asking about their cultural impact. Sometimes culture can impact providers that they bring into the system. It can impact medications and medication choice. We have a couple of cases right now that are culturally based in their decision to want to look at more holistic approaches. And that is completely reasonable. And we're supporting them with those decisions. So again, we want to ensure that we are across the board keeping that in mind and ensuring that they feel supported by that. At times, we've encountered systems where they wanted providers that were within their same culture. So we made referrals and supported them in doing that. It wasn't a negative thing. We just ensured that they were able to get that support. And again, providing education as to why recommendations are being made and how we can support them. Linguistically, we come into language barriers, and we have to work through how we best support them. We have a new case right now where the care manager is able to translate for us, but we have very easily learned that none of their providers speak Creole, and they are solely Creole speaking, and the care manager cannot go on every appointment, as I'm sure Kathleen would be able to validate, as much as she may want to. Every medical appointment, every start appointment, it's very difficult. And so decisions are being made, medications are being changed, but the family really does not understand any of it. School, they have no understanding of what's happening in school, again, because of the language barriers. So when we come in as START, and what we want our systems to be looking at is that cultural and linguistic approach, and ensuring that their needs are being met regardless of those barriers, and we're able to break down those barriers. So that is the end of this presentation today. So I'm going to unshare my screen and open it up to any questions, any comments, for myself or Andy, or about the case with Lisa. Any feedback for George? I know we made quite a few recommendations in a couple of the slides, and I'm sure Lisa took some notes throughout what Andy and I were talking about as well. But does anyone else have any recommendations for George that we can bring back to the system? Silence. Bob, do you have anything you'd like to add?
No, I don't. This was really very interesting. Thank you.
Thank you, Bob. All right, so I'm going to let us end with Lisa. If Lisa, you can just give a very brief overview of the recommendations that you gathered throughout the conversation and throughout the training that you will bring back to the system, and we'll end on that note. So Lisa?
Absolutely. Well, first, again, thank you guys again for participating, and for Dr. Kent and Elise for pulling this together. This was really, really helpful and amazing, and I appreciate all the discussion. So I will, one of the recommendations I took would be to start to open some more lines of communication with the psychiatrist. I like the idea of opening those lines via email and kind of keeping that flow going. I know that in certain cases it can be overwhelming, but I think in this case that would be really, really helpful for us to be able to keep track and kind of really understand how often these medications are being changed or what is going on. Then I loved Alex's recommendations on therapy focused on self-esteem and self-confidence. So I think that securing a therapist, as we recently learned that George was discharged from his therapy and psychiatrist. So to locate a therapist that can focus with George on self-esteem and self-confidence, maybe making some time for personal fitness and exercise, possibly taking some online classes or researching if there's any book clubs. I really like the idea of the local library. So I kind of wrote that down too as a suggestion, because I know that they always have really good classes. And then focusing on relationship building. So maybe researching some social groups that we can explore for George that are local. He does have to live in a very accessible area. So I think that that's going to be something to look forward to. And I also think that just on the relationship building note, to just kind of talk to the house about maybe doing some almost like team building, but with the house and the guys, because they do have some sort of common interests. And I think that might be nice, and really add some more opportunities for PERMA into George's life. We did talk about the resource center, Mona. I love that recommendation. I know that there are some budgeting barriers right now. We did attempt to implement START therapeutic coaching in the past. I know that we've had some staffing challenges, but I am hopeful for the future. So we can definitely revisit that in order to kind of, again, add some structure.
He is first on our list once we get the billing mechanism to bring in group home individuals for the resource center. He is first on our list, as well as the individual that Kathleen was talking about earlier. Not at the same time, but they are both on that list. So yes, Mona, I definitely appreciate that insight. We're just waiting for the mechanism to bring him in.
Yep, right. All that red tape. But yeah, hopefully that will be helpful, because I really do feel too that environment would be so therapeutic for him. I also we'll follow up with the team regarding the lithium and the thyroid monitoring. I did not realize that had such a big impact. So I'm sure that I'm not the only one there. So I will provide some education to the team and just kind of encourage some follow-up there. And also monitoring the Hashimoto's to make sure that George is getting that regular blood work. From my understanding, he is, but also it seems that we've had a lot of systemic changes recently. So I think that it would be worth a follow-up, and also somebody who is so, it's typical for George to refuse appointments, refuse medications, refuse kind of blood work like that. So I think that it would be really important to just monitor that and how that's going. Also the hypoglycemia. George is somebody who does report feeling panicky often. He's also somebody who tends not to eat very often and has to be reminded to. So I think that just ensuring that he's on a regimen of some structured nutrition plan and kind of sticking to that almost like he would stick to a medication regimen might be helpful. Understanding, planning and preparing the team for that anticipated non-compliance or, refusal as he's allowed to, but just kind of taking notes is like, hey, George, I understand that you're feeling very, panicky right now. However, you haven't eaten since 8 this morning and now it's 3 p.m. And I wonder if you'd feel better after you ate. So that might be something that we can kind of walk the residents through. And then also just exploring more opportunities for PERMA. I think that there are, that now that things are kind of going back to, we don't know. We don't know if they're opening or closing, but we'll explore the environment as it stands to, kind of look around and see if we can incorporate some of that PERMA plus into George's life, because I think it's definitely greatly needed. And, it will, one of us does better, we all do better. So hopefully the residents, the staff and also George's housemates looking at George and kind of making these improvements will hopefully spread that positivity.
Absolutely. And Caitlin, I hope that as our representative from the residential team, we can work very collaborative with you to put some of these things in place. We talked about some of the challenges that we've had. So I'm glad that you were here, and hopefully Lisa can work collaboratively with you with this system to put some of this in action.
Yeah, definitely. I appreciate this so much. And Lisa, I love the idea of PERMA. I think just even some of the staff at the house learning what PERMA is for their own life too, coping skill wise, it could be super beneficial. And I will share this with the assistant director when she returns. And we did just hire a brand new BIS for that resident. So I'll inform him about some of this stuff too and touch base. So thank you so much, guys.
Great. Thanks, Caitlin. And I did record this. So Caitlin, we can have them have a recording of it if you'd like for them to watch it. That would be lovely.
That'd actually be really awesome. I'd love to pass that along to the new BIS.
I will, when I send Lisa the link, I will also send it to you.
Thank you for inviting me. It was very informational.
Thank you, Kathleen. I hope you'll join us again.
And invite other people to come too, Kathleen.
Yes, spread the word, Kathleen. Thank you, everyone, for coming and participating. We are not doing a CET in September, but we will be back in October, the last Friday of the month. So we will see you then.
All right. Thank you.
Thank you.